Claudia Nieuwoudt. I'm a maternal fetal medicine fellow at Prisma Health at the University of South Carolina in Greenville. And I'm here discussing with Dr. Jack Sobel today non-Albicans candidiasis and vulvovaginitis.
Okay, so my name is Jack Sobel. I'm a professor of medicine, and I work and have worked at the Wayne State University School of Medicine, and I have an interest in vulvovaginal infections, vulvovaginal disease in general. I have a vaginitis clinic and a research laboratory, and have a specific interest in infections caused by Candida species, as well as bacterial infections, but I think we're going to talk today about Candida infections.
So to start with, it's a very nice comprehensive review. My background, I actually worked as a OBGYN for a few years before going back and doing fellowship, so this was an issue that I often encountered in the outpatient practice. So reading the article, one of the things that you emphasized and that I wanted your advice on is, what would you tell the clinician who has a patient in the office with a subjective concern for vaginal candidiasis, and how do you pass out your patient who potentially is symptomatic from something that's not a Candida infection? Are there any markers for you that when you hear that you think this is not likely to be Candida? Because as you've mentioned, not all patients with a non-Albicans infection actually have a virulent or a pathogenic strain of non-Albicans candidiasis.
So your single question is actually 20 questions.
Sure.
So most of the infections caused by Candida species are caused by Candida albicans.
Right.
And the diagnosis of Candida albicans infections begins from when the patient walks into the room and gives you their history, and you sit down and talk and you look at the individual and the risk based on their lifestyle of getting Candida infections and so on. And then your physical examination. At the end of your physical examination, that together with your history, you now have your differential diagnosis, which is narrow. Then you look at your pH, and you'll start your microscopy, which unfortunately many clinicians don't have the time to do. From my perspective, most Candida infections cause an inflammatory reaction. So you will see both vulvar as well as vaginal manifestations, recognizing that in yeast infections, the actual signs, the edema, the irritation, the itching, the redness, the fissures, are a response of the host's immune response to the yeast, not by the yeast directly invading the tissue per se. So when a person has a history compatible with Candida infections, with the yeast infection, itching, burning, so on, a recent exposure, recent course of antibiotics, etc., taking diabetic that's lost control, etc. In other words, the history is always suggestive of the infection. Then your physical finds corroborate what you've seen. Then you usually find a normal pH, with the yeast infection. Not always, but yes. And then you do your microscopy. With your microscopy, you may be able to confirm the presence of yeast, to get a better idea of what kind of yeast you're dealing with. So if you see, for example, many blastospores and pseudohyphae and hyphae on microscopy, you have a high likelihood you're dealing with C. albicans. Most of the non-Albican species do not form hyphae that you can identify in microscopy, with microscopy. You usually identify the non-Albican species only after you get the results of a culture results or molecular analysis technique where they look at the DNA and so on. But if I see somebody who's got a compatible history and a compatible physical appearance with normal pH, and I've seen hyphae and pseudo-hyphae, and the morphology as an experienced clinician, I can tell you that it's likely to be albicans. Then putting them all together, I can say to the patient with 90 to 95% certainty, you are dealing with an acute or chronic Candida yeast infection. It's most likely caused by C. albicans. I can't tell them that with 100% certainty because there may be a second cause or tertiary cause. And sometimes the yeast per se, without hyphae, can be just colonizing. In other words, they could be commensals. So it's important to try and establish as a clinician with every patient whether you have proven causation or causality. In other words, you've seen yeast and you believe it's causing the symptoms. And in most women who've got a classic yeast infection caused by C. albicans, which is the common variety of infection we see, you'll be able to say with a 95% certainty that this is that the yeast are present and are the cause of the symptoms and need to be treated. You can't always predict the response to therapy because the patient could occasionally, not frequently, have resistance. C. albicans doesn't frequently have resistance. Unfortunately, C. albicans resistance is increasing. It is a major problem which was not described 20 years ago, 30 years ago. It's a new phenomenon, the phenomenon of C. albicans being resistant to azoles, which are the basic drugs. Right. One only becomes aware of the non-albicans organism as a result of the culture. For experienced microscopists, however, they will also see blastospores of different sizes and shapes. With a saline microscopy, that'll give them a clue, and you can identify Candida glabrata, which is different from the morphology of Candida krusei, Candida parapsilosis. There are only about 5 or 6 different Candida species that make up the other 10%, but they're increasing in number, and they don't form hyphae. If you see large numbers of species of blastospores of a certain morphology and no hyphae and pseudohyphae, then you could say this looks like it's going to be a non-Albicans Candida species. But most of the time, it's after the culture results come back. In the past, most of the culture techniques didn't actually identify the non-Albicans species. You would get back the results, non-Albicans Candida. Today, however, with the transition from culture to the more widely used, commercially available PCR methodologies, the PCR methodologies are more likely to tell you that this is going to be glabrata or krusei or something else. So whether there's a true increase in non-Albican species or else it's now being reported by virtue of the new molecular methodology more frequently, the clinician is going to be confronted more frequently by non-Albicans Candida species. Now, all the non-Albicans Candida species have several things in common, and this is sort of my message. One, they tend to be less virulent in general, by which I mean they're less capable of causing symptoms and more likely to be commensals. Not always, unfortunately not in every symptomatic patient. Two, when found, proving causality or causation, which I explained to you previously, is much more difficult. So it's harder to find, harder to recognize, and harder to prove that actually it's causing symptoms. Furthermore, the symptoms that you get for the many of these non-Albicans Candida are confined to the vagina, where they may cause burning, they may cause irritation, they may cause pain. They less commonly cause vulvar expression with edema, fissure formation, and edema. That certainly is the case with the most common non-Albicans Candida species, Candida glabrata. But Candida parapsilosis and krusei can also cause vulvar manifestations which are indistinguishable from those of albicans. The next characteristic that is unique to the Non-Albicans Candida species. As a general rule, they tend to be more azole resistant. They may be very azole resistant, as is the case, for example, with glabrata, and therefore much more likely, if they are azole resistant, they are more likely to persist in the presence of azole drugs. And you will remember that azoles are the very foundation of all treatment of antifungal infections. Very few drugs available for use on non-azoles. So they're a complex group. You can't put them all into one bucket, although I've just put them into one bucket. And they are different. They have different susceptibilities. They tend to be azole resistant. And they are less well known by practitioners. With the increased reporting from molecular laboratories about their presence, whether it's glabrata or Cruzia or whatever it is, the practitioners now are exposed to these diagnostic entities more frequently today, often panic, have never heard of these organisms, and don't know what to do, hence the referral to vaginitis experts. And they constitute a major treatment challenge because they are resistant to conventional therapy, they're more capable of persisting, and they more frequently are actually not involved in causation of the symptomatology. So it can be a chronic irritation or chronic pain caused by vulvodynia. The patient may have a pudendal neuralgia, the patient may have vulvodynia from many other causes. And the glabrata are sitting there, and they are more likely to be what we call innocent bystanders. So it's stuff. So determining whether the patient is whether the organism is involved in causing symptoms or not and needs to be treated, and less likely to respond to conventional therapy, is problematic.
It's the diagnostic dilemma of this, right?
So it's an enormous diagnostic dilemma. You are 100% correct. And looking down the microscope, you do not establish causation. Getting a molecular test, you do not establish causation. None of the tests available establish causation. Causation is based on ruling out other causes, identifying whether the clinical syndrome is compatible with the yeast species identified, and responding to therapy. The only way you can be certain that the organism is or is not involved is by a trial of therapy. Trial of therapy. What is a trial of therapy? This is a foreign concept to most doctors. It means using certain drugs for a reasonable, effective period of time and seeing whether you can eradicate the organism, at least on a temporary basis, and whether you impact and influence the presence or absence of symptomatology. If you treat the yeast goes away and is not present on reculturing. You have to reculture these patients. The culture now turns negative and the patient's symptoms disappear. You now are starting to establish causation for that incident. The yeast has definitely gone away. Symptoms have definitely disappeared. You've got a reasonable chance to have established causation. Not for the same 95% that you had with the Candida albicans.
Sure.
If the patient says, my symptoms have gone away, and you do your microscopy and you see she's just full of the same organism with thousands of blastospores.
Yeah.
And she says this, then you've established that the yeast are not causing the symptoms. The symptoms have improved, whatever the mechanism there, or vice versa. It's not easy to prove causation. And the trial of therapy is often that is given by the practitioner is often too short to be fair. You've got to give it for at least 2 to 3 weeks. You've got to try and eradicate the organism and see what happens with the symptoms in establishing causality.
So you bring up azole resistance, and I like those last few sentences that you said. Brings up a clinical situation to mind where we have patients that say, hey, I'm about to take antibiotics. Can you give me a prescription for fluconazole just for a day? Or they call in, hey, I just need fluconazole for this. What would you say to those clinicians about that practice, especially in light of this rising azole resistance?
Well, as the person who first invented fluconazole prophylaxis 25 years ago, I feel a little guilty.
Okay.
There's no question that if Mrs. Smith is prone to recurrent Candida infections of any sort, and it's usually and I've seen her in the past, and I know she responds to Candida, to fluconazole. She's received appropriate therapy. And I know from talking to her and seeing her on a regular basis that she is prone to yeast, and I've seen her with these yeast infections. I certainly do not want her to take antibiotics whether they're inappropriate or not appropriate, inappropriate, without protection. The best protection is with giving her simultaneous antifungal therapy. The most, so that could be with clotrimazole or miconazole per vagina, or it could be with fluconazole by mouth. It's so convenient to give her fluconazole by mouth. Giving her one tablet and my practice has been one prophylactic tablet of 150 milligrams with onset of the antibiotic therapy, and usually at the end of the week of antibiotic therapy, 5 or 7 days of antibiotics, and give it a second treatment. One tablet of fluconazole provides therapeutic concentrations in the vagina for 48 to 72 hours, up to often 96 hours, and so therefore she will not get a breakthrough infection. So prophylaxis can be appropriate, can be reasonable. I don't do it every single time. I give it to the right patient. As always, the most important message, don't generalize. Treat each patient individually. Have this little equation in your head as you prescribe any medication based on the merits and justification in that individual patient.
One more question to diagnostics.
Yes.
Earlier you had mentioned that with the emergence of testing options, particularly with PCR testing and now being able to do fungal cultures, at least it's more commercially available. You have the benefit of being in a vulvovaginitis clinic, so I imagine that this is something that you do often. But for the general clinician, I have mostly been in settings where I do microscopy first. I would not call myself an experienced microscopist by any stretch of the imagination, and I have never even tried to differentiate albicans and glabrata or non-albicans in general. What would you say would be your recommended threshold for the inexperienced microscopist to reach for the DNA probe or reach for a fungal culture if it's not routine practice? It's not always financially feasible either to do these additional tests.
Well, for decades we opposed anybody doing anything but a good microscopy. We now realize that's ridiculous because most people are not going to be doing microscopy. So we now welcome reliable laboratory tests done commercially that are usually covered by insurers, and therefore we welcome every effort made by the practitioner to confirm the diagnosis. So if microscopy is done but doesn't reveal the diagnosis, or microscopy is negative, but the person is symptomatic, if you don't have a diagnosis, get a molecular answer as soon as you can. The DNA probes alone, for which there are a couple of tests, are going to be entirely replaced by molecular tests which are based purely on PCR. PCR will be replaced by PCR. And they will be covered by the insurance. We want diagnostic confirmation. The patient should demand diagnostic confirmation. The practitioners owe the patient accuracy of diagnosis. And certainly the more the more persistent the infection, the more recurrent the infection, none of this should be based on empiricism. Empiricism is the enemy, to be used only on rare occasions where the patient has severe symptoms and you have to achieve relief as soon as possible. Otherwise, no empiricism. So, we welcome commercial molecular tests, hopefully as quick ones, and we are looking at a period ahead of us where we will be dealing with point of care molecular tests. In other words, they may take half an hour, or an hour, even 2 hours for the test to be done using molecular methodologies, or PCR available, recognizing that the next chapter of the whole commercial diagnostic methodology will be based on next generation sequencing, etc. We don't know whether the very complex next generation sequencing methodology is going to be an advantage for the most women who are symptomatic, and they'll certainly be more expensive.
Right.
It's already available. I'm not sure it's any better in most women. Some women, absolutely, knowing all the organisms present will be an advantage. But I think it's the exception rather than the rule.
I imagine that microscopy will eventually fall away.
Not
unfortunately.
not in my clinic.
Good. And I taking care of an indigent population, self-pay patients, it remains the cheapest test, and something I will continue to do.
I hope so.
Yeah.
Thank you.
Yeah.